So now that we've talked about the intricacies of autorhythmic cells, those are the pacemaker cells, and the contractile cells in the myocardium, let's zoom out a little bit and look at these pathways in a slightly less magnified manner. So first we can see in the intrinsic conduction system, that's the system that is intrinsic inside of the heart itself. We see the SA node, which is the sinoatrial node, and that node generally regulates heartbeat at about 100 beats per minute. It's modulated by the atrioventricular node, which is in this wall between, or this kind of septum between the atria and the ventricles. That conducts heart rate at about 40 beats per minute. So between the two, general heartbeat is about 75 beats per minute. And you can measure heart rate in adults by palpating the radial artery, or in children by looking at the brachial artery. Now there's a delay between these two nodes, or between these two collections of nerves, that's about 0.1 seconds, about 1 millisecond. Then the signal moves through the atrioventricular bundle and then into these bundle branches, which supply, as you can see, the intraventricular septum, some of the walls of the atria, and the papillary muscles. From there, the signal moves into the Purkinje fibers, and those supply the rest of the ventricular wall. So the goal here is, with that delay, for the two atria to contract and then the two ventricles to contract, so that blood is pushed from the atria to the ventricles, and then from the ventricles to the pulmonary trunk or the aorta. So you can see that here in this animation, where the atria contract first and then the ventricles. I'm going to slow it down a little bit so you can see it and hear it better. Occasionally there are problems with this intrinsic conduction system. One of those might be an arrhythmia, which is the lack of a rhythmic beat. A good heartbeat should be like music. It should have good beat, be regular, be easy to dance to. Fibrillation, particularly ventricular fibrillation, refers to rapid irregular tachycardia, or rapid irregular fast heart rate over 100 beats per minute. And in that case, the ventricles spurt out blood instead of delivering a large enough stroke volume. You can also have heart block, or AV block, in which the atrioventricular node is insufficient or incapacitated. So now let's look at the extrinsic innervation of the heart. That's regulated by the autonomic nervous system, the parasympathetic and the sympathetic nervous system, mostly via the vagus nerve. So the centers for regulation of heart rate are in the medulla oblongata, which is regulated or obligated to regulate your vital signs. The cardioacceleratory center sends out signals via sympathetic pathways that increased heart rate and the force of contraction of the myocardium, meaning how strongly that muscle contracts. The parasympathetic pathway gets its signals from the cardio-inhibitory center and thus slows down heart rate. So what you're likely to see in a person who's come into your office or into your ER who's excited or scared or in pain or nervous about a diagnosis maybe is extremely elevated vital signs, extremely elevated pulse, rapid pulse, extremely high blood pressure, and potentially panting maybe or hyperventilating. Then we can diagnose or look for a piece of the diagnostic picture and looking at an EKG or an ECG, which is a picture, that's the gram, of the electrical activity of the heart, and that refers to that intrinsic conduction system. So if we look at the P wave at the beginning is caused by depolarization of the atria, of the SA node, and that's the beginning of the action potential in the SA node. The end of the P wave, or that horizontal line at the end of the P wave, is as the atria are finishing their contraction, the QRS complex looks at or sees the activity from the ventricular depolarization, the beginning of the signal as it moves through the AV node to the AV bundle to the bundle branches and the Purkinje fibers. And that very strong depolarization also masks atrial relaxation or atrial depolarization. The end of the QRS complex shows the end of ventricular depolarization, and the T wave, which is also small like the P wave, shows repolarization or relaxation of the ventricles just after they've ejected, hopefully, most of their blood. At the end of the T wave, ventricular relaxation is complete or is done. So depending on the profession that you plan to go into, you may be required to analyze EKGs, and this is a single lead. Oftentimes what you'll see in practices now are 10 lead or 12 lead EKGs that show multiple tracings, and then you have to accumulate that data. Now, the top one we see here is normal sinus rhythm, normal heartbeat, and if you know how much each of the squares here represents in terms of time, you could figure out heart rate from the ECG. Many machines now will tell you heart rate. They'll tell you if it's normal. They'll tell you what kind of problem might be occurring in the ECG, just to make things faster and simpler for patients and patient care. At the very bottom, we see an ECG that should cause alarm in your head because it's ventricular fibrillation, which could easily lead to death. And you see erratic contraction. There's no discernible P wave, T wave, or QRS complex. So it's really hard to tell where contraction is occurring, whether it's occurring more strongly in the atria or the ventricles. This is a case that needs to be addressed immediately. And question number 14A is to list the structures and functions of the intrinsic conduction pathway. And 14B is to list the structures and events of the extrinsic pathway.